Catherine Such from Brighton Pediatrics. Is there anyone else? Kevin, did anyone throw anything in the chat to say they were a new add to our group today? No?
I'm not seeing any new.
Okay. All right, well, we'll get started then. I just want to review the agenda. Welcome. We've done that one already. We want to talk with you about medical supply savings opportunity, and we have a guest speaker here, and I'll introduce him in a moment to talk to you about that. Elizabeth Sharp, our Director of Optimization, is going to be giving a team update. I'll be talking about some upcoming incentives, things, checks you'll be receiving in the mail, as well as talking about our new provider incentive plan. I want to introduce a topic to you about practice champions. It's a concept I've been thinking a lot about for our primary care practices, and I'm looking for some feedback from our primary care practices on. And then a quick recap of our 2021 employer health plans. So with that, I'll get started with the medical supply savings opportunity. I want to introduce Christopher Earl. He is the VP of Corporate Accounts at Medline, and Chris will run over what Medline is exactly. But just to give you a little background on why Chris is with us this morning and why we're bringing this topic to you, as our primary care practices are aware, and some of our specialists are aware, we have been provisioning to AHP practices some PPE, things that, when the pandemic started, because of the allocation system for PPE, things you didn't ordinarily need in such great volume that you then did need in great volume, you weren't able to get a hold of. AHP has been able to tap into some of the UR Medicine supply chain and donations and things like that to provision to our practices, gloves and gowns and just PPE. What this is meant for AHP, and while we've been so pleased to be able to provide this to practices that were in need, is that first of all, we're limited in resources to be able to do it, and the amount of PPE we're giving you is a very narrow band of what's available. We only, as you know, AHP is not a particularly top-heavy organization. We don't have tons of staff to manage a PPE supply chain, so it just hasn't been sustainable. And it's frankly not convenient for the practices to have to come every other week, fill out a survey, drive to Corporate Woods to pick up their package, or, fingers crossed, get it delivered by UPS, which has had its challenges. So through the efforts of Kim Povek and our medical director, Chad Teeters, they work closely with UR Medicine and Chris at Medline and another vendor you'll learn more about called Vizient to talk about ways that we could give access to AHP participating practices, all AHP participating practice, not just primary care. That's been another limitation of what we've been able to do. We're not resourced to give all of our specialists access to PPE. But through this partnership with Medline and Vizient, give you access to the same pricing really that UR Medicine gets for medical supplies, including PPE. So not just gowns and gloves and things like that, but everything that your office typically orders and needs to conduct medical practice. So I'm going to turn it over to Chris now to talk about the specifics of this program. Kim Povek is on the call as well, and she's welcome to chime in of anything I mischaracterized or neglected to include in that intro. But I'll turn it over to Chris, and I've got your slides loaded, Chris, so just tell me when you're ready to advance.
Awesome. Thanks, Renee, and thanks, Kim, for the opportunity to connect with your practice managers this morning. Everyone, my name is Chris Earl. I'm Vice President of Corporate Accounts here at Medline Industries, and we're really excited about this partnership to help provide you with better access to PPE products, very, very aggressive pricing based on the University of Rochester relationship. And we hope an overall better vendor experience to access your medical supplies. So if you have any questions during this presentation, please feel free to interrupt me or even put them in the chat box, Renee. If there's anything that you'd like to maybe moderator that comes through, please feel free to stop me and ask me. But I just want to give you a quick overview of who Medline is, what our goal of the program with AHP is aimed to deliver, and how you, if you'd like to participate, how you can connect with me and engage and get the ball rolling really for this program. So Renee, if you could go to the next slide, you can go to the next one as well. We Medline are, I'm not sure if anyone's heard of us today, but we cover the entire continuum of healthcare. So we service University of Rochester as the main vendor, but we also service every aspect of healthcare, whether they're surgery centers, home health, retail, and specifically your marketplace physician offices. So you may be familiar with a few other distributors out there like a McKesson, a Henry Schein, and some other smaller distributors. We Medline are very comparable to those, but the big difference is that we Medline are as close to the supply chain as you can get. We manufacture about 40% of the products that we sell. And that's really what I think Kim and Renee found attractive for this partnership, is that we're very close to the supply chain and are able to help deliver a lot of PPE products that you may be struggling to get today. So Renee, if you can maybe go to the next slide for me. I just want to kind of let you know that we're a huge manufacturer. So you might be able to buy our products today through your distributor that you're using. But if you're able to buy them direct, we're able to offer such a significant large cost savings that a few cost studies that we did, the savings were upwards of 20 to 30%. So if you could skip ahead, Renee, to the next slide. I just kind of threw a couple slides here together that the big differentiator between Medline as a distributor and a few of the other ones that you might be using today is that we truly are a manufacturer. We're making gloves, we're making gowns, we're making PPE masks, procedure trays, pain trays, a lot of the products that you might be using in your offices today. And so with the help of the University of Rochester in this program, we're really able to help deliver aggressive pricing and hopefully some cost savings for your offices. Renee, if you can maybe go to the next slide for me. Aside from the Medline brand products, which we're able to deliver, we also are able to deliver any national brand product that you're using today, whether it's your 3M, your BD needles, your Midmark tables, your vital signs from Hillrom or Welch Allen or Roche. We truly are a one-stop shop for all of your medical supply needs. And just wanted to let you know, if there's any questions, please feel free to reach out. But the main goal of this program really is to help deliver PPE and cost-effective solutions for your practices. Renee, if you can maybe go to the next slide. This is just a quick little overview of Medline. We have I think we're over to 60 now. We were in the mid 50s last year, but we just are now over 60 distribution centers across the country. So we truly are one of the nation's largest providers of medical supplies for health systems. So you're not dealing with a smaller company. We really understand your needs and have seen whatever you're working with today across the country. So we're excited to partner with you. So Renee, maybe if you could go to the next slide for me. Here's a few notable names of some health systems that we work with. You'll notice the University of Rochester is on there, and we're really excited to partner with AHP. The next slide, real quick, I wanted to give you a quick overview of Medline, how we work and how we operate. And please feel free to chime in with any questions or concerns or thoughts. But we Medline have a dedicated sales force for the physician office marketplace. Some other organizations that you may purchase supplies through may call on different types of facilities throughout healthcare. Our reps are trained in the physician office landscape, so we know physician offices and those specialties inside and out. So part of the AHP program is each facility will have a dedicated field rep, which used to be able to go into the offices, but probably are doing things mostly virtual right now. But on top of that, you'll have a dedicated customer service rep internally that can help you with orders, returns, a number of other things. So the next thing is if you place an order by 3 p.m., you'll be able to have your products next day, which is really, really nice. I know that a later cutoff for next day delivery can really help some offices. We have free shipping on orders over $150. What we're going to do for the first 6 months of this program is waive any shipping fees, so you can get acclimated to working with a new vendor. We have a lot of things we can do behind the scenes to help with your contracts, make sure that you're connected to the best and most aggressive pricing possible, really based off of what the U of R is accessing today. And then we can pretty much accommodate any type of ordering that you may do, whether it's .com or if you're working with a formulary today. We can really help in any way with respect to placing and servicing your orders. Renee, maybe you could jump to the next slide for me. So overall, we have a guaranteed save program for AHP members. We did 2 pilot offices. We did the colorectal surgeons and the panorama pediatrics. Their savings were upwards of 25% on their annual spend, which really equate to significant dollars. One of the largest things as well is we're going to have the members be able to have access to our robust spot buy program, where you're able to purchase some gloves, gowns, masks, wipes, critical items that are in need right now. So we really hope that you use us for these programs.
Chris, do you mind if I'm sorry, do you mind if I jump in quick?
Yes, please.
No, one of the things that surprised me while Renee and I were working with Chris is when he brought back the cost study. So in essence, we asked these practices for just their invoices, and Chris took them and bumped it up against his system. And so the 25% savings, it was simply if you ordered the same product through Medline. And then a whole other batch of savings, which were significantly more if you switched to a Medline product. And so the savings were upwards of 40% in some cases if a practice switched fully to a Medline product. So I like to throw that out there, and I appreciate the conservative number that Chris shares here. So this is if you were to get the same exact product. And we have written into the contract a guaranteed, I believe it's 8 to 10% savings. So regardless. So I just wanted to throw that out there too, Chris.
Yeah, thanks, Kim. And that's a really good point. We wanted to be conservative with our savings numbers, but the two practices that we've worked with so far, the savings could potentially be up into the 40% range. And that 25% that Kim mentioned is really, you're purchasing the same BD needle, the same 3M item, the same national brand product that you may be buying today through another distributor. It's going to come in on a Medline truck. It's going to come in the same packaging. It's just that we, as part of this program, are accessing pricing from the hospital that is so much lower than what you're able to access today as a single practice. So that's really, I think, where the value is coming from, Kim. The next part is we, Medline, as a manufacturer, making gowns, drapes, gloves, all those other types of things. If you're looking for additional savings, you may be buying a McKesson brand table paper or McKesson brand item today. We, Medline, have equivalents to all those products and would love for you to try and sample and let us know if you'd like to switch over to some of those. We think there's some significant savings there as well. So aside from the med surgical products, we, Medline, have a lot of things that we can help with today with around courses for your staff to take continuing education courses. We have some solutions that can help with your materials management. So there's a lot of value adds that we, Medline, have. But I think the biggest thing today is we really think that we can help with your PPE through our spot buy program, as well as help drive savings for the exact same items you're using today, really just accessing better pricing through the U of R program. So I'll pause there, Kim. I want to see if there's any questions, thoughts, feedback from the group here this morning, and hopefully I can answer some questions.
I also want to mention, Chris, that Nicole from Vizient is on the call now.
Oh, great. Hey, Nicole, how are you?
Good morning. Sorry, I was having some computer issues this morning.
No problem at all. And I'll pause there. I think that's a good segue. Nicole Davis is from Vizient. Vizient is the organization. It's called the GPO, a group purchasing organization. And that's who the University of Rochester uses. Nicole is a counterpart that I work with from Vizient. Her role in this whole program really is Vizient, her organization, is who negotiates and has all these awesome contracts that we're able to access and give you phenomenal pricing. So Nicole, I'll pause there and see if maybe you want to just introduce yourself and kind of elaborate on anything I mentioned about the program, and if you have any additional comments.
Sure. Good morning. So I am Nicole Davis. I'm the Vizient non-acute account executive. And what I do is I work with, specifically University of Rochester Health System, but multiple health systems across, I think 4 or 5 states, and primarily focus on the off-site practices. So there's definitely a lot of complex things that you have to work with. And so Chris and I work behind the scenes to make sure that, the suppliers are approving the pricing and that we have these AHP sites aligned with the health systems contracts that are currently accessing. So a lot of the stuff, I don't think that most of you will, speak to me on a regular basis. You probably would work with Medline, but Chris and I are working behind the scenes along with University of Rochester to get these suppliers and contracts approved.
Awesome. Thanks, Nicole, too. And I thought it'd be worth mentioning, aside from the medical supply savings, which I think is really the main focus of this program, you at Vizient have a lot of other contracts out there that the offices may want to take advantage of. So as we're sending out communication from Kim and Renee, we're going to send some information out. Vizient's additional contracts. Maybe Nicole, you could touch on some of those common categories.
Purchase today that wouldn't go through Medline. So some of those things might be like Xerox or landscaping services, elevator services, and even employee savings. So I do want to point that out as well. And I'll speak to Russ because I know he's spearheading these conversations regarding the purchase services program. But we also offer personal employee savings as well. So I, as an employee of Vizient, take advantage of savings just going to the movies, pre-COVID, or just using a moving services. So not only are you going to access savings outside of your regular medical supplies, pharmacy purchases, but we also have significant other areas where you can save money through purchase services. And I'll ensure that Russell has that employee savings brochure as well. So it's a very simple process. You just create a login through your AHP email, and you're able to access thousands of savings through our program as well. So it's really a great program. Very little need asked from the individuals of AHP as far as the practice managers. And, we're here to kind of save you as much money as possible and get you aligned with the health system, which will be very beneficial for all of the offsite locations.
Awesome.
Nicole,
thanks, Nicole.
Russ and I have had a chance to talk, and we want to get the supply chain side off the ground first.
Yes.
We're going to integrate some of those extra savings a few months in.
Okay, perfect.
The other thing I'll add in here quickly too is oftentimes what comes to mind, legal issues. So just to know, we've been in touch with U of R Legal, with our own legal counsel, and everyone has signed off and feels very comfortable with this arrangement. There were some questions regarding Stark Law, but everything, the lawyers worked everything out, so we're in a good place there too.
Perfect.
Awesome. Renee, Kim, any questions from the group? Has anyone worked with Medline previously? Any comments, feedback, questions that we could answer at this time?
So there's no questions from the group, Chris, but I think a good thing to cover is, where do we go from here? What are the next steps?
Excellent.
How do people connect with these savings?
Yes, excellent. So I believe, Renee and Kim, you are going to be sending out some information to the membership, kind of like an introductory to say, hey, we partner with Medline, and here's some basic information about the program. But if there's any practices that would really like to take advantage of this program and get things rolling, they can contact me directly. My information's here. I'll make sure that Kim and Renee can pass it off to the group. But reach out to me, and what we'll do is we'll connect and try to really understand what your needs are. Are they PPE? Are you looking for cost savings? And we can really run an analysis of your most commonly used supplies and do a tailored cost study that will show your savings for your office. And then from there, we can set you up with a Medline account, make sure that you are connected to the Vizient purchasing group, which will give you access to all the pricing that we're providing. And we're really off to the races. It's not terribly complicated, but the first step is just to reach out to myself, and we can set up a quick virtual call and really run through the program in a little bit more detail.
But this does require a contract, right? Practices will need to sign a contract with Vizient and a contract with Medline, correct?
That's correct. Yeah, it's really just a new account form, right? They're not obligated to purchase from us in any capacity. They're not mandated to do anything. Really, it's just setting up an account number with Medline and a member ID with Vizient. So don't feel like you're obligated to take part in the program. We'd love for you to do so. It's really just setting up an account with Medline and Vizient so you can access everything.
And if a practice called you today and said, I'm in, Chris, what are the steps and what's the time frame before they're actually plugged in and getting access to this pricing and to these supplies?
Sure. So if they called me today, first thing we would do is have them set up an account. We can have them an account number turned around in about a day. And from there, they really could start accessing the PPE program immediately. So we have a brochure or a spot buy program that comes out every single Friday with updated supplies on there. from gloves, masks, and gowns, and I can definitely send over some information about our glove programs as well. If they were looking to fully transition to Medline as their main supplier to take advantage of the cost savings, we have a program or a process called implementation. And what we really want to do is make sure that we bring into stock and have the pricing correct for everything you're purchasing. Every office is different, and we really want to give it a bit of time. So the smaller offices, we could transition much quicker, but the larger practices that may have multiple locations or whatever it is, a full transition actually takes around 90 days. And that gives you time to wean down your current supplier and gives us time to bring inventory and stock in to make sure that we're stocking everything that you need for that next day delivery. But everything's customizable. Those are kind of the ground rules. But the big thing is, big takeaway I really think is the PPE program. We could start that immediately with any of the end users here that are struggling with supply needs. And then if they're looking to transition to Medline as their supplier, we can talk through an implementation program and go from there.
And the last thing I'm going to chime in here, Chris is being a bit humble, and Renee's arrow is spot on. Chris and his team have been absolutely fantastic to work with. Renee and I truly have been blown away at the ease and the knowledge. And we were, again, completely impressed by the savings. I don't think we were expecting it to be that much. So we really we'd encourage you all, connect with Chris, see what the savings potential could be, just switching over from your typical products and even exploring some of the Medline products as well. Yeah, we're excited about what this could mean for all of you.
Thanks, Kim. Yeah, I think you're right. I was being a little humble with the savings, but we were expecting somewhere between 10 and 15%, but we were able to drive almost 30 to 40% savings for some of the offices. So love to work with anybody here. If you have any questions or would like to participate, feel free to give me a call today or email me and we can schedule a time to talk and dive into this a little bit more.
Thanks, Chris.
Thank you.
Any questions before we lose Chris or Nicole from Vizient? Okay, I guess you want to save your questions for one-on-one. Oh, did I hear someone pop up with a question? No? Okay. Thanks a lot, Chris. I mean, guys, this is such a great opportunity, to save your practice so much money annually. And it's not only the great pricing, it's the better availability as well. I think is important to emphasize. I just, seeing what the pandemic has done in terms of your access to PPE, this is a chance to help mitigate what that impact has been on your practice. So we will be reaching out, but if you want to get ahead of the game, feel free to contact Chris directly and get the ball rolling. So
excellent.
Does no delivery fee mean no fuel surcharge fee?
Good question. Yeah, we do not charge fuel. We do not have a fuel surcharge fee. Our flat order is, say a year from now, over $150, it's free shipping. And what we really like to do is work with each practice to try to establish a ship schedule. So, your routine orders are placed on Monday and are delivered on Tuesday or, a couple days a week, whatever it is. But no shipping charges for the first 6 months for anyone that takes part in this program, so you can get used to working with a new vendor. And we hope that drives some practices towards us and some interest.
Great. Thanks for the question, Tanya. Okay, well, we'll move along then to our next topic. Thanks a lot, Chris. Have a great day. Have a nice holiday. If we don't talk to you again, but we will.
Take care. I'm going to jump off as well.
Thanks, Nicole. Bye-bye. Thanks for joining us this morning.
Take care. Have a good day. You
too. Okay, optimization team update from Elizabeth Sharp, our Director of Performance Optimization. I'll advance slides in a second, Elizabeth. I'm just having a problem with my mouse here, so bear with me. Start talking, though. You're on mute.
I was following directions and talking, though, I promise. Good morning, everybody. Hope everyone is doing well. Wanted to join today to give folks a brief update on the optimization team, what we're currently focused on, and what we're anticipating for 2021. So I'm going to do a quick review of our diabetic year-end sprint, and then shift over to talk about our focus for 2021 from a behavioral health, which is sort of the lifespan, our adult and our pediatric. Acknowledge the near future when I'll code all time view. So I know that these issues may be a little bit lower down your priority list, but wanted to let you know what we were thinking about anyways. So for our diabetic year-end sprint, we identified some contractual areas that need support as we roll into the end of 2020. We are focusing on diabetic measures for a couple of our contracts, and we sent out lists last week. Again, this is for our adult and family practices, family medicine practices. So the list that went out were patients who have visits scheduled before the end of the year who have diabetic gaps, and patients who don't have visits scheduled before the end of the year. We're also engaging the AHP care management team to try and take some of the burden off of the practices. But our goal here is to really address the needs of the patients that are coming into the office and engage with the patients that aren't scheduled, whether that means bringing them into the office, asking them to go into a lab, or working with them at home to kind of ensure that we're getting them that needed care. I'm keeping this very brief. As I said, those lists went out last week. If you got an email, that means you have a couple of patients identified. If you have any questions about the patients on the list or what we're hoping to accomplish, please feel free to reach out to me directly. Before I flip over to 2021, does anybody have any questions about that diabetic? Okay, I think we're good, Renee. Thanks. So our focus for 2021, we're going to continue to focus on depression screen and follow-up. I think many of you have received an email, oh gosh, it was in October, with your practices depression screen data. We do have the depression screen and follow-up quality measure in Arcadia, and Willie Nudigat, who's on the line today, has been doing quite a bit of work with individual practices to validate that data. So in 2021, we're going to continue to work on increasing depression screening rates across the network. We have a goal of increasing it by 50%. And the different challenges for the patients who come in who are only coming in for an acute visit. So we really want to make sure we're integrating this depression screening with the PHQ-2 and PHQ-9 to that preventive, the preventive visit and the annual physicals. We're also going to be continuing to optimize the quality measure, that depression screen and follow-up. And that's going to roll out in a couple of different ways. We're developing a depression plan of care. We've been piloting that and are working on making sure it kind of carries through to Arcadia and closes the gap in that quality measure. We're going to continue to do data validation with individual practices to ensure that the work that you're being done is, counted, if you will. And our behavioral health integration team is available to work with practices to ensure comfort level with both the screen and the appropriate follow-up options. We have a toolkit online. They have their Tuesday calls, but you can also reach out to them directly for consultation on individual patients. So we're really working on kind of educating the practices, making sure folks are comfortable with what options you have, especially knowing that we have, a shortage of available appointments with behavioral health specialists in the area. Go to the, does anybody have any questions about depression? I was gonna say everybody's got it right now, right? Rolling into the dark times. Okay, moving on.
I feel like an expert.
I know, seriously. I saw a meme a little while ago. It said, welcome to 2020. If you don't have a general anxiety disorder, one will be assigned to you. And I thought that was pretty funny. Moving on to diabetic eye exams. So the IRIS implementation continues. I think this is familiar to many of you. We have a number of practices who have engaged with IRIS to do point of care diabetic eye testing. So to have a camera in their practices. We got 2020'd, if you will. The first training was supposed to happen on March 17th. So obviously that got canceled. It was supposed to be in person. And IRIS actually pivoted to virtual training. So we've trained a number of our practices. Again, we are working on that data validation piece. So making sure that the screens that are done in the office are flowing through to Arcadia and closing that quality measure gap. And really working on integrating it to the practice workflow. So we do have a couple practices where we've trained and it's really kind of humming along. We have a couple practices who have trained, who need a refresher or need to be able to prioritize it, but just aren't able to. So We are going to complete that work in 2021, finish our rollout, and hopefully see some really, really good numbers and increased screening, especially for the patients that have trouble accessing specialists. On to the next. So diabetic A1C. In looking at our numbers right now, we've noticed that our performance is trending down on our contracts for diabetic A1C when we look at the trailing year perspective. And we're attributing this to the fact that there are more, I'm calling them COVID months, in the trailing year view. So there are more months where patients are less likely to come into the office. They may not be comfortable. Practices may be prioritizing more urgent care. And so we want to make sure that we're still going away. And so we need to be a little bit creative with how we're targeting March. It doesn't make a lot of sense to do it before then because of all the holidays. And then at the beginning of the year, we want to give folks a chance to kind of transition. And we're going to look at a number of different options. Obviously, bringing the patients into the office would be great if that's available. If not, we could consider doing a lab push with a telemedicine review. We're going to have AHP care management support and AHP pharmacy support engaged as well. So we don't have this fully fleshed out as an initiative just yet, but we know it's going to be a focus. It's going to be really important. You know, I'm sitting in my home office and I'm way too close to my kitchen and my pantry right now, and I imagine everyone else is doing the same. So we want to make sure that we bring these diabetic patients in, if not into the office, at least into care in 2021. So we're going to be coming up with some hopefully creative ways to be able to engage them. The other thing we're planning on focusing on next year is hypertension blood pressure control. The rationale for this is threefold, actually. We are concerned about the impact of COVID on these patients, whether or not they're going to get into the office so we can get that blood pressure taken, and what that result will do to their care. We've identified this measure as one with a large racial disparity. So AHP is focused on, right now, on racism as a healthcare crisis. And in hypertensive blood pressure control is one measure in particular where we've noted a very large disparity in performance based on race. And so that is an area of concern for us. There's also potential measure definition changes coming down the line eventually in the targets to achieve. So right now we're looking at a blood pressure of less than 140 and less than 90. It's entirely possible that those numbers will go down in the future. And so the measure definition could change and become a little bit tighter. So we want to make sure that we're working towards control in that sense moving forward. From an action perspective, what this means for the racial disparity piece, we need to validate the data we have available. We do have some data available in Arcadia, but we're not sure how much we trust it just yet. So we want to take a look at that. And we need to determine how to address the inequities that we've identified. From a COVID response potential definition change perspective, we are considering looking into at-home blood pressure readings, and again, that telemedicine review with the patient. Again, if we can bring patients into the office, all the better. And again, pulling in AHP care management and AHP pharmacy support. So this is something you'll be hearing about in 2021, hopefully earlier on in the year, so that we can give folks some time to spool up and take a stab at this. I put our pediatric initiatives on the same slide because, and I'm actually going to start with the bottom bullet. It's my own fault. From a quality measure perspective, I have this COVID response here. So we've got immunizations, lead, and well child. And I'd like to give a very big shout out to our pediatric community because we've done an absolutely incredible job on immunizations in 2020. I read articles in the New York Times about how horrible childhood immunization rates are across the nation, and it's not the case in Rochester. By prioritizing those essential visits, we've kept our immunization rates up, and actually in our Medicaid population, we've increased our immunization rates in 2020 over 2019, which absolutely blows my mind. I'm very excited about it. So I think that locally, you keep hearing, oh, we don't want a measles outbreak on top of COVID. I think that locally, we've done a really wonderful job in paying attention to that and making it a priority. That being said, we want to continue to do so in 2021, and also keep an eye on our lead screening, and in particular, those well child visits. That's been a challenge this year. As we focused on the immunizations, the well child visits were not as much of a priority earlier on in the year. There's been a huge push recently, and we've seen a lot of improvement. A lot of those kids are getting in to see their doctors, which is great. So we're going to keep an eye on that. So you may be hearing from us about particular quality measures next year. I'm just not sure what it's going to be yet. We're going to kind of need to keep an eye on the data and see how things are going. We're also talking with Dr. Shipley, our pediatric medical director, about comprehensive pediatric screenings. So we have a focus on the first 1,000 days, and we're talking about developing a pilot with a practice or two to define and implement comprehensive pediatric screenings. So identifying what those screenings are, at which visits they should be done, making sure they're built into the EMR, really building out the whole program so that if and when we roll this out to the whole network, we'll have a comprehensive package for folks to engage with. Whew, I just talked a lot. Does anybody have any questions? Okay, so in 2021, we're really going to be focusing on the basics. We're cognizant of the fact that you all have a lot going on and we don't want to overwhelm, but we are going to be, paying attention to the top priorities and engaging you as we need to. Thanks.
Great. Thanks, Elizabeth. As I always do after Elizabeth's presentation or any discussion about the quality measures, I always lead into upcoming incentives because it's so important for me to make sure that all of you remember that it's our performance to these things that really drives AHP's ability to deliver these incentives to you, to earn the gain sharing that we've earned. The diabetic sprint that Elizabeth referenced, that those communications, they did go out, Elizabeth, or they are going out? They're out.
They went out last Tuesday.
Okay. We just ask that you, please help us out here and get those patients in as best you can. We do have some of our payer contracts or employer contracts where performance under diabetic measures really needs that year-end boost. So we appreciate all your efforts on that. So incentives, upcoming incentives. What is coming in the mail? What is Santa bringing you for the remainder of this year in terms of AHP incentive dollars? So I want to talk about clinical integration, board and committee fees, and then 2020 gain sharing. So when it comes to clinical integration, I really want to back up and make sure everyone understands what we're doing or what we have already done with regard to clinical integration. So clinical integration, when I say that is that quarterly payment that you're receiving from AHP. It's the dollar per member per month for all of your providers attributed Excellus and MVP patients, all lines of business. We have kind of messed with that schedule a little bit this year in terms of those payments to get dollars into your hands in light of the pandemic. So I just want to review how that went down. So to put it all in context for you. So far in 2020, we've paid you 3 times. We started on April 15th with a first quarter 2020 estimate. We didn't have, however, the first quarter 2020 attribution from the payers. It wasn't available yet in April, and we felt this compelling need to get these dollars out to your practice. We didn't feel like you could wait, and we didn't want you to wait. So we put out a payment that we called the first quarter 20 estimate, and what it was based on was your fourth quarter 2019 attribution. So whatever your attribution was for fourth quarter 2019, we paid you that dollar PMPM on that basis, and it was an estimate. Then, come June, we did have the numbers from the payers. So on June 18th, we pushed out to you an actual first quarter 2020 clinical integration payment based on your actual first quarter 2020 numbers. Okay, so that was June 18th. And just also to remind you, for both April and June, for most practices who've shared their information with us, these dollars are appearing in your account. We're paying you electronically. We're not sending paper checks. And we're sending you the check detail via email. It's either coming from myself or it's coming from Kevin, okay? So far in 2020, April 15th, June 18th. Then October 15th, we paid you second quarter 2020, which is the period April 1st through June 30th, based on your actual second quarter 2020 attribution, but we reconciled it against the first quarter estimate, okay? The estimate was an estimate. So we wanted to make it right. We needed to reconcile those two payments. So what you did is, so if your attribution went up from that estimate, you really received just a small check. And if your attribution went down, you didn't receive a check at all. Okay, so what we've done is reconciled it. So your second quarter payment, if you received one, was very small because we netted out what we paid you in that estimate. That brings us up to present. Third quarter clinical integration, which is ready to go now. So that's going to be your July 1st through September 30th numbers. It's going to include all your enrolled APPs, their attribution, and that electronic payment is scheduled for Wednesday, December 2nd, which usually means it's our understanding that it appears in your account the next day, Thursday, December 3rd, but I hear from a lot of you on the same day. So I'm going to say some of you may see it very well on Wednesday, December 2nd, and we'll email you that check detail. So for practices that did not receive a second quarter check because your attribution went down, right? Referencing this right here, your attribution went down. Those practices will see that small amount netted from this payment, and that's going to complete that reconciliation. Okay. If you did receive a check last time, that means your attribution went up, and you're all good, you're all whole, you're fully reconciled, and your third quarter clinical integration check is going to be your full third quarter clinical integration based on your actual attribution. So, long story short, for 2020, you're still getting 4 clinical integration payments. You're going to get first, second, third, and fourth quarter, but that estimate has been reconciled, and it was reconciled against the second quarter payment. Okay, I know that is super confusing. Our CFO has walked me through it a million times to help me try and make the best explanation as possible to you all. Some of you I've talked to on the phone because it's been confusing. If you have similar concerns or questions, feel free to give me a call, but I'm hoping that clears it up. But bottom line, third quarter clinical integration, your $PMPM for your Excellus and MVP members is going out the door Wednesday, December 2nd, and it'll be in your account, and we'll follow that up with the check detail, okay? So holler if there's any questions about that. Then the next incentive for those of you who have providers who participate on the AHP board or in any AHP committees like the Adult PCP Advisory Committee or the Pediatric PCP Advisory Committee, those meeting stipends will be going out the week of December 21st. And that will be a full year of those meeting stipends. With COVID, with the amount of cash we've been putting out, the multiple extra payments we've been making, we gave ourselves a break. We did not do a mid-year payment on meeting stipends. So the full amount will be sent out 12/21. Now, these are paid to your individual providers for the most part. Some of you, if your doc is participating on this and you're in a solo practice, they may have said, yeah, pay the practice, in which case the check will be sent to the practice. But the vast majority of these payments are made to the individual provider, mailed to the address on their W-9 because it's paid under that individual provider's social security number. So if your providers are asking about the mysterious check that they received at their home address from AHP, it is most likely this board or committee stipend payment that they'll be receiving the third week of December. Okay. Any questions about that? Pop up or pop off in the chat. And then finally, 2020 gain sharing. So you may be surprised to see this on this agenda because it was just this past September that we paid you for 2019 gain sharing. But we want to talk about 2020 gain sharing now because in light of what an exceptional year, exceptional seems to be the wrong word because exceptional seems positive, what an extraordinary year 2020 has been due to the pandemic, we are in really good shape for the 2020 performance year to have really beaten the budget and be eligible to earn a ton of gain sharing. And because of that, our payers are recognizing that we are very much in this position, and they're willing to advance to us what they believe we will earn for 2020 gain sharing. So rather than make everyone wait until September of next year to receive what was earned for the 2020 performance year, we're going to do a gain sharing advance. We are going to pay out to you sometime prior to 12/24, pending approval by the AHP board. Have to make that point. Our AHP board needs to sign off on this plan. We are going to pay to you exactly, pretty much, what was paid to you in 2019 gain sharing. And that will be an advance against your 2020 gain sharing. Okay, so that check you received in September, if our board approves this methodology, this plan, you will be receiving a check, right after Christmas, in that same amount, and that'll be in advance. So when we do settle up with the payers, when in 2021 we're looking back at the 2020 performance year and seeing what we earned, we're going to have to reconcile that. And for some folks, you might get a little more, and for some, you might not get anything. But I doubt that. So we'll keep you informed, but just want to make you aware, you're going to be getting this, most likely going to be getting this payment right after Christmas. It's going to be the same size as your 2019 gain sharing that you received in September of this year. Any questions about that? Can I get a All right. See, Elizabeth came on camera just to make me feel better. Thank you, Elizabeth. If there's no questions about that, I'm going to move on to our provider incentive program, because thank you, Carolyn from Penfield Pediatrics, for the woohoo. Much appreciated. And Jerry from Westside Pediatrics. See, the Peds people are all about it. Okay, provider incentive program. We are making some changes that I want to walk through with you. And I'm really actually just introducing this topic, because the changes I'm talking about, you're really not going to see until 2022. Okay, so we have lots of time to talk about it, and this will be an introduction to it. So let's talk about how we've been incentivizing your providers for quality historically or now. Okay, so right now we are paying out really two quality incentives based on your primary care provider's performance to quality on the Arcadia Analytics dashboard. Okay, so the first one is just a quality incentive that we pay for the performance year. So let's use 2019 because that's our most recently completed full performance year. And for 2019, we paid your providers a quality incentive in March of 2020 because we need that time to get the claims run out and do all that good stuff to really understand that snapshot of 2019, how you did. And the source of those funds that we pay that quality incentive are the clinical integration dollars that payers give to us, that we also pass through some to you in the forms of the clinical integration payments that we just talked about. And we pay it on the basis of your percentage of points captured in the Arcadia Analytics dashboard. If you are bronze, that means you've earned between 0 to 65% of the points you're eligible, all the way up to gold, where you've earned 90% or more of the points that you're eligible for. And that incentive has been, $5,000, $6,000 at the gold level, pretty much. Okay, so that's the first way that we've incentivized quality. March and the year following the performance year, and based on that percentage of points captured. And then gain sharing also has a quality component. The gain sharing currently, or to date, has included a base amount that we pay to all providers, just for being in the network, and it's pretty much a flat amount that's paid to every provider. PCPs all get the same base amount. Specialists all get the same base amount. Attribution. Folks are getting an attribution amount based on the size of their Arcadia patient panel. And then finally, there's the quality component, which is just a mirror, a snapshot, the same snapshot for what we paid you in March. Okay, but gain sharing, the source of those funds is gain sharing. So of course it's pretty it's variable, and we're paying it in August or September following the performance year. So for 2019, you received your gain sharing, which included this quality component, in August or September. So that's what has been to date, really the sum total of the incentives that we're on a regular basis, that we've baked in, that we're paying PCPs for their performance to quality as it's measured in the Arcadia Analytics dashboard. But what has occurred to us as we have contemplated incentives is that, for the lion's share of these incentives are derived from gain sharing. And how do we earn gain sharing? And we talk about this all the time when we talk about our contracts. Well, we earn gain sharing by saving money and improving quality. We have to care for the population at a cost that was less than what was budgeted in order to have a delta to share, right? We got to beat the budget. And we have to meet the quality goals. And the issue here is that the current incentive plan only rewards one half of that equation. It is only rewarding meeting the quality goals. And the quality goals, of course, are very important. But if we don't beat the budget in the first place, there is no savings. There is no delta to share with our providers. So we need to find a way to not only have our providers focused on their quality performance, but also focused on their performance to cost and how their actions and behaviors drive our performance to budget under our value-based contracts. So we have rejiggered, so to speak, our provider incentive program to do that, to bring the cost performance into the equation of what we incentivize. So what we're contemplating, and again, we don't anticipate this taking effect really until the 2021 performance year, which will mean payments in 2022. So what we're doing is we are eliminating that March payment, that quality incentive. We're getting rid of it altogether. And we are moving to a value incentive that is entirely based on gain sharing and some of those clinical integration dollars, a blended source of funding for the value incentive. We anticipate that there will no longer be a base, there will no longer be an attribution, but rather, and I'm sorry, it looks like this is cutting off here. So I'm gonna stop sharing and share a new view of this slide with you because it's cutting off. Bear with me here. So I know that's like a smaller version of it, but at least you can now see to the bottom of it. Maybe if I just move this whole thing up here. There we go. We'll do that instead. Okay. Sorry, guys. Sorry about the interruption, but I really want to make sure you see the whole picture here. Okay, that's better. Okay, so the proposed incentive plan is going to eliminate base, it's going to eliminate attribution, and it's going to up the ante on the incentivizing for performance under quality and cost. So this value incentive, 60% of the value incentive will still be the performance to the quality measures. Okay, it's still going to include the Arcadia quality performance based on the percentage of points captured, but we're going to get rid of the bronze level. So to earn that 60% of the value incentive that you're eligible for, you're going to either at the minimum earn silver. You're going to have to at least capture 65% or more of the points that you're eligible to capture. And so the silver and the gold levels will be maintained. Providers, however, with fewer than 500 attributed lives. So these are our providers who have just smaller panels, or maybe in a region where they don't have a lot of attributed lives, that are covered by our value-based contract. They're eligible up to the silver level for this. Then we're going to incentive 30% of the value incentive is going to be paid based on the provider's performance to IPC, Integrated Practice Committee. So these are our clinical programs or clinical initiatives like post-acute care that you've heard about or that your providers have heard about. I'm not sure we talked about that one with this group, or the 5-Touch Readmissions Project. These are initiatives that, while obviously also have an aspect of improving outcomes, are also about improving the value of care, improving cost performance. Certainly, everyone on this call understands how improving, reducing unnecessary readmissions to the hospital will mean better budget performance under our value-based contract. We've eliminated an unnecessary trip to the hospital. That's money saved. So we're going to be making 30% of a provider's incentive based on their performance to these IPC initiatives, and also pharmacy targets that are set that you'll hear about more from our pharmacy team. Did we identify a specific drug that represents a big spend under our value-based contracts? And did a provider successfully change his prescribing patterns to reduce the number of patients on that particular drug? That saves us money under our value-based contracts, and that means positive performance under the cost aspect of the value-based incentive or the value incentive. And then finally, we've added a citizenship category. This will only be 10% of the incentive, and it's meant to incentivize participation in high-value engagement activities. We'll be looking at your citizenship performance based first on a practice level. Is the practice engaged? Is the practice, are practice managers attending this meeting? Are your providers, do you have a practice champion assigned? And we'll talk more about practice champions in a minute. As a practice, are you engaged in what we're doing? And then on an individual basis as well, if there's any issue, if the practice perhaps isn't necessarily satisfying the citizenship requirements, individual providers may still satisfy the citizenship requirements by participating in a committee, by accepting email communications with us, things like that. As I mentioned, this is our conversation right now, or my soliloquy on this topic, not really a conversation, is meant to just introduce the topic. We have lots of time to go over this. I'm absolutely, of course, want to answer your questions about it, but you'll be hearing more and more about this in the coming months about the incentive plan. So please don't think that the lack of detail means we're not fully baked here. I'm just trying to do a soft introduction for everyone to this topic, okay? So how will a provider know that they're doing okay and that they're performing well to what's expected of them? Well, another topic I'm going to just introduce briefly is the provider engagement report. So this is something that our team has been working on quite a bit. We don't have anything ready to show you yet, but what this report is a quarterly report that's going to replace the former triple aim report. And it's going to provide a snapshot of the quality, which the old triple aim report really did, right? It showed you, red, green, and yellow, how you were doing to your Arcadia measures. But it's also going to include this new report, the performance to those IPC projects, to the pharmacy projects. Are those behaviors changing? Are you performing in a way that's beneficial to our cost performance under contract? That'll be outlined on this quarterly provider engagement report. So that's going to help individual providers and practices, the entire practice, understand their progress towards earning their value incentive, and on a quarterly basis. So by the first or second quarter, know, wow, if I want to earn my full 30% in the cost aspect of the value incentive, I'm going to need to change more patients off of this drug and move them to the generic. Or activities like that. Or if I want to earn my 60% of my quality measure portion of the value incentive, I need to improve my diabetic measures across the board. So, we don't want at the end, it's just like a performance review or a report card, right? You shouldn't wait to the end of the year to know, did I please my boss? Did I please my teacher, right? You need to get those updates all along the way. And that's what this provider engagement report, or PER, as Kim likes to call it, so she can include a cat icon on this slide. It's kind of cute. It's meant to do. It's meant to make sure that your providers are fully plugged into what is expected of them, and how they're doing, what their progress is towards meeting the thresholds and goals that we're setting. So we are anticipating that the provider engagement report will start going out early next year. We will absolutely be showing this group a mock-up of what that's going to contain, because it's likely to be addressed to you. We'll be talking about with you our plans for how do we get your provider engaged around these reports, and get our medical directors in front of your providers to talk through their performance. And I guess we'll leave it there, that there's just really a lot more to come on this topic. That was a lot. Are there any questions that the group is willing to share now, or throw in the chat about provider engagement report, about incentives? No? Okay. All right. Again, tons more to come. So moving on to practice champions. And this is one now where, if you thought my last pause was long and uncomfortable, when I finish this topic, it's going to be even longer and more uncomfortable, because I really need your feedback on this one. I really want to hear from you on what you think about this concept of something that we're considering doing. We're calling this practice champions, and our reason for thinking about a model like assigning an AHP specific or designating an AHP specific practice champion in each practice. Why do we feel we need that? Well, we've got limited AHP resources. We've got 3 medical directors. We've got 2 provider relations staff. We're lean and mean, right? And we want to be able to engage practices in a really efficient and effective way, because we're growing. We've got more practices, and we need to be efficient about the way we reach out to you. COVID, obviously, we'll just leave that in one word about why engaging practices has been more problematic. We can't just swing by your practice anymore. We can't have face-to-face meetings in person. We have a growing number of initiatives that really, in order to get you engaged around and for us to really get into the weeds with you about what we're looking for, we need FaceTime of some ilk, at least, even if it's Zoom. Our current modes of communication really aren't assigning accountability to participants. That's a fancy way of saying, I'm going to use the PCP advisory committee as an example. We have tons of PCPs who go to that meeting, but they don't really feel accountable to leave that meeting and go back to their practice and share what they heard with their practice partners and amplify our message. Would accept that responsibility to ensure that all the practice stakeholders understand their the expectations AHP is looking for. And also, a practice champion is going to help us. It's going to help AHP by giving us some practice-specific feedback that's going to help inform our AHP initiative development and inform our communications. We're going to have someone, a go-to person in the practice, who's going to tell us, this isn't working for us, or this is what we would need out of this initiative in order to make it successful. We're really looking for, excuse me, a designated partner in the practice. Hold on a second. Chew on that while I get a drink. Okay. So what are the specific responsibilities that we would be looking for in a practice champion? Well, I went through someone who's willing to advocate for AHP within the practice, that they're going to talk to their practice partners and their practice manager. Hey, AHP needs to do this. I think it's good for our patients. I think it's good for our practice. And they need these resources, or they need these actions out of this. How do we make it happen? You know, someone who's going to quarterback the effort within the practice. And then they're going to serve almost like as a subject matter expert for all things AHP to the practice. They're going to work with us they might not have all the answers, but they're going to know where to go to for the answers. The practice champion would serve as the representative to the advisory committee, and the practice champion would be the point person for meeting with AHP to talk about the provider engagement report, and then they'd be the point person to sit down with the practice partners at your weekly or your monthly meeting to talk about the report and what expectations there are, and talk about the progress towards incentive, and make statements like, hey guys, if we all do X, Y, and Z, we'll increase our incentive from this to that. Someone who's going to come in and really translate in a way what AHP is trying to accomplish in the context of the practice. And then, serve as a general purpose liaison between the practice and AHP, not trying to dismantle existing relationships, right? We have lots of other points of contact in your practice. We have administrative contacts, often you, the practice manager, right? We have an IT contact. We have a clinical contact. We don't want to disrupt those. So sometimes those relationships don't always, you've got a lot of priorities. You're busy people. Sometimes if we're not getting traction with a designated contact, it would be helpful to have a champion to whom we could escalate and say, hey, I know, our IT contact in your practice is really busy, but we really need this. Can you run a little interference with us and get me that call back, or get me that response to the email? That's what the champion would do. And we think it's important too that as we talk about who in your practice would be a good person to be a champion, we think it's important that it's someone who is active in clinical practice, and that they work in your practice at least 75% full time. Someone who's really with the practice day to day, and someone who really believes in what AHP is doing, right? Who has a passion for value-based care and has some interest in the relationship. Someone who's a natural leader, they're ready to perform in a leadership role. Obviously, someone with strong communication skills. And this is important. Someone who's really knowledgeable and proficient with your EMR. Your larger practices, you guys know, you've got docs who get the EMR. You have docs who don't. We would be interested in having a doc who does get your EMR serve as a practice champion. And then we want this to be a clinical person. A physician or an APP would both be fantastic. And it's our plan as well that if this idea gets traction, if we think this is something that would work for you and would work for us, we want to compensate your practice champion by way of a monthly stipend, in recognition of this. It takes time, this takes hours, and also a recognition that if we're looking for accountability here, right? We're looking for someone who's going to be responsible to do these things. Well, we want to pay them for it, and we think the pay helps support that our search for accountability. So, what do you think? Your initial reactions, this is good, or I've got docs who would do this, or this, no, I got no one in my practice who would agree to do something like that. What do you think is a reasonable monthly stipend? Open it up. Let me hear what you have to say. If you're on the phone and you're on mute, you most likely are, just hit *6 to unmute yourself. But I want to hear what your thoughts are about this concept.
So Renee, this is Chris from Stony Brook Peds.
Hi, Chris.
Hi. I think this is a good idea. I think we already kind of have somebody that does this for us, Katie Edwards. So the only thing is she doesn't see patients full-time. She's only part-time clinician because she does so much administrative already. So I don't know if that would be an issue for us, but I think it's a great idea.
Okay, that's a good point. And I think when I think of the 3/4 FTE, not necessarily that the clinical portion needs to be 3/4, but as long as they are practicing clinically and all total their time in your practice is at least 3/4 full time. I think that's great.
Yeah, definitely. So I mean, for us, I would move to have her because she's already doing it. So
okay.
No,
Yeah,
it's a nice idea.
That's great. And if she's already doing it, and she deserves to be, compensated for what is an extra effort.
Sure. No, I think that's very nice of AHP to put that on the table as well.
Chris, thanks for breaking the seal on the comments. We've got something from Beth. I think it's probably Beth from Lattimore. I think this is in the chat. I think that this year has been so overwhelming that the thought of anyone taking on additional tasks will be too much. No, understand that. I really do. I get it. And that's why we're also willing to put in the stipend. And the thinking is that, and first of all, this is not something we're planning on getting done in this calendar year. And the hope is that when the pandemic is is being managed better and is impacting us less and less over time, day to day, that this was something that we could roll into. So point well taken, though, Beth. Thank you for that comment. And if you think Beth and Chris are, covered it all for the rest of you, it's only 9:14. I only have 5 minutes worth more of stuff to talk about, so I can stay silent for a little more. What do you think? What do you think is a fair monthly stipend for this kind of work? I was thinking maybe $200 a month was a figure I was kicking around. Remember, it's *6 to unmute yourself. I'll say this while I'm waiting for you to chime in, that for those of you that are in solo practices, although many of you, even if you only have one physician, a lot of you do have an APP, so maybe that's the case. But for those of you that truly only have one clinical provider, that clinical provider would be the person we would want to designate as a champion and would want to, because they're functioning on this. But with, there's variability there from solo doc to solo doc. Formalizing this role will result in more accountability and a feeling more accountable to helping AHP meet its goals. Anyone else want to say anything? Anyone else want to? Oh, here we go. Jerry from Westside, I think $200 is a fair amount. Aaron from Panorama, could this be shared between an administrative and a clinical person? I might be more successful with this if I was able to share the duties between the two. I think that's a good suggestion. I think that's something that I would want to talk to you more about, Erin, of how you think that would work. And is it something that's really scalable to all practices, or is it something that, you know, works more for yours than for other practices? But I think that's a really good point. Anyone else? I won't torture you much longer.
Hey,
Okay.
Renee,
We have
Melissa from Finger Lakes Health. Just
Hi, Melissa.
Is there any estimate about how much time per month this is going to take? We've tossed a lot of stuff onto our providers recently, and I know they're really aware of how much they value and providing as much clinical time as they can, and not really being too heavy on administrative stuff. So in terms of the stipend and the amount of time and making it a value to them, can you give any estimate on how much you think it might take per month?
Sure. I'm going to say I would think anywhere between at the base amount, 2 hours a month, at the top end, 4 or 5 hours a month, and that would be, you know, variable month to month. It'd be depending on what's in the hopper. You know, I mean, what I'm thinking of here is, you know, there's 8 PCP advisory committee meetings a month. That's an hour and a half a month right there. There's, you know, maybe taking a meeting with Chad to go over the provider engagement report. You know, that's going to be on a quarterly basis, and that's going to be a half an hour phone call. You know, some of it's going to be bits and pieces, right, Melissa? Like, let's say Sam Barron at AHP is working on a data coordination project, and he's having trouble getting a hold of your IT contact. That's answering an email from Sam to just say, yeah, thanks for letting me know, Sam. I'll make sure, you know, Susie gives you a call. That kind of thing. So my hope is that it represents that while the function is critical, that the commitment, hopefully, that in terms of time, is de minimis. Does that answer your question, Melissa?
It does, and I actually do like the idea of trying to split it between an administrative and a clinical person. You know, we already have practice champions for PCMH in most of our practices, and we'd have to identify a couple of new people, which I think we could do. But I want to make certain that we're splitting duties as best we can, and if there's an administrative portion that someone else can take care of, that'd be great. I fully agree with the clinical portion, you know, getting the provider on board and making certain that they are really working with staff and championing the practice to push forward those quality measures.
Okay. Thanks, Melissa. That's great feedback. Sounds like there's some consensus that sharing the responsibility would be a good add to the program. We do have a comment that I received in the chat directly. In our practice, I feel that designating a provider to be the go-to would really just put the tasks on the practice manager. The MD would likely not be the one actually performing the duties. So I think that speaks to exactly that comment of the shared responsibility, and we have to find a way then to make sure that everyone in the equation feels appropriately incentivized. This has been very helpful. Thank you very much. Is there anything else before I move on? I welcome your comments as well. You can email them to me directly or give me a call if you want to talk more about this. I absolutely will have this topic on our next practice manager's agenda. Okay. Thanks, guys. That was very helpful. I really appreciate the feedback. And then our final item on the agenda is to go over our 2021 employer contracts. So these are our contracts with FF Thompson, Highland Hospital, and the U of R Health Plan. This is the deal where when patients who are covered by these plans see your providers, they're paying less out of pocket because they're an AHP. An AHP is the tier 1 network for these health plans, okay? So I just this is gonna give you an overview of the changes to these plans, okay? FF Thompson, 2021 changes to the FF Thompson Health Plan, nothing that affects you. It's new. There is a higher tier 3 deductible, but as you all are tier 1 providers, that really doesn't matter. So just as a quick overview, the FF Thompson Health Plan only has the Excelis TPA. It's got about 1,500 members. They've got 2 health plans, the high deductible and the higher deductible. This is what their cards look like. It has the VYA prefix. And the only change to this plan is that their tier 3 deductibles on their high deductible health plan, not the higher, went up. Okay, so nothing really that impacts this group at all. So I will move along. For the Highland Hospital Health Plan, there are absolutely no changes to this plan. This is the plan that has about 3,000 members. They have 2 TPAs, Excelis, Blue Cross Blue Shield, and MVP. And their MVP cards look like that and say Highland Hospital. And their Excelis cards look like that. And I don't believe they have a unique prefix. Although I feel like I've asked that question before and not gotten an answer, but I'm going to make a note of that to follow up on, because and slides will be made available to you, and those will be recorded and uploaded to our YouTube channel if you want to look at those more slowly. Changes to the U of R health plan. Well, there is one major change for 2021, and that is the U of R health plan is moving to 1 TPA. So Excelis will be it for the U of R health plan. They are eliminating Aetna as a TPA. But I do want to remind you of the big change from 2020, which is that there is no routine eye benefit anymore that is included in the U of R health plan. If I need an annual eye exam, I have to pay for it out of pocket. My health plan does not cover it, or I can purchase VSP as an optional coverage that the university does now offer. So the big change there, again, for 2021, only 1 TPA, Excelis, and carrying over from 2020, the routine eye benefit is gone. So again, to remind folks, this is our biggest employer health plan with 35,000 members. As I've noted, there's only 1 TPA starting in 2021, and that's going to be Excelis. And I want to point out that this is kind of, this will, I think, benefit AHP and our performance under this health plan contract is that we will now have access to claims for all U of R health plan members, and claims go a long way in satisfying quality measures. We never did have access to Aetna claims, so this will really, I think, help bolster our performance under the University of Rochester Health Plan, because now that they're going to the single TPA, we have access to claims for all of their members. And that's what the Excelis cards look like. The Aetna card is going away, and the prefix for the U of R health plan for Excelis is and will remain URL. And there are no other changes to the health plan. This just lays out the individual for each plan, the copay plan and the HSA eligible, and you can go over those at your leisure with the recording or the slides when we send those out. Reminder to folks, for these health plans, for patients covered by these plans, if you have claims problems, for example, we're a tier 1 provider, but the U of R health plan members are processing, their claims are processing with tier 2 benefits, or this service isn't tiered under the U of R health plan, but the claim is still processing with a tier 2 copay when it should process with a tier 1 copay. When those problems crop up, I want to remind you, what do? First of all, contact Excelis. I can now get rid of, well, no, I guess I still should say TPA since we still have MVP in the mix for Highland. Contact the TPA. First thing to do, contact that TPA, Excelis or MVP. Confirm the tier 1 status of the provider, or confirm that the service is not tiered. If you don't get any joy there, if they're telling you we can't fix this, then you need to contact AHP, and we will work with that TPA and make sure that you are set up correctly in their system to reflect your tier 1 status because you participate in AHP. Okay. And as my reminder that I give everyone all the time, for these, obviously we want you to keep your patients in network regardless of them being covered by employer health plans, but it's particularly beneficial to those patients covered by these health plans that you refer them to AHP specialists, hospitals, imaging and labs, because they pay less. So that's it on health plans. Any questions about our 2021 health plans that I can answer? I remind folks how important it is to make sure that everyone in your practice knows that you are an AHP, that when members of these health plans are calling your office, that person at the front end answering the phone knows to say, yes, we are participating in AHP. Because if they don't know that, then that health plan member doesn't think you're tier 1 and isn't going to go to your provider for the services they need. So if there aren't any questions, we've reached the end of our program. I thank everyone for all of your work this year, all of your participation and engagement with the network. Everything we've accomplished is thanks to so much of your efforts. It's been an extraordinary year, and I'm looking forward to 2021. That's maybe hopefully a little less extraordinary. I hope you accept my wishes for you and your family to have a lovely holiday season together. And when I say your family together, I mean your immediate household members. And I hope you all have a lovely holiday. If there is nothing else, I will end the call and thank you all and hope you have a great day. Okay, bye folks. Kevin, I think you're the host. You've got to end us.
All right. See ya.
Okay.
Thank you.